without further ado, I'm going to have Dr. Peng to speak first. And one note that Dr. Peng's ICU unit have treated over 100 people with COVID-19 and has achieved the lowest death rate at 20%. On average, the ICU unit death rate is about 60%. So we're really fortunate that he just came out of his work to join us. And so Dr. Peng, the floor is yours.
Hi, hello everyone. It's my great honor to share my experience. I'm Dr. Peng from Wuhan University. Thank you for inviting me. So here I will briefly talk about the lesson we learned from COVID-19 outbreak in Wuhan. And here I will briefly talk about the following contents: how to prepare the outbreak, and the general feature of the COVID-19, and how to diagnose the COVID-19, and how to manage the critical ill patients with COVID-19 and outcome of the patients with COVID-19. So actually, this figure told us how this problem spread quickly within 3 weeks from Wuhan to all over the world. And so here we should prepare for the outbreak. So actually, in the beginning of the outbreak, the medical resource always limited. So we need to prepare first. So for the medical beds, for the ICU beds, it's always not enough. Also for the human resources, not enough, especially for the specialists, including the ICU doctors, ICU nurses, not enough. So we should mobilize the medical resources through the whole hospital, or through the whole city, or even through the whole state. And also we need to organize the new teams, especially for us, because I am intensivist. I was asked to organize 2 other new teams, including the physician from other specialty. So this is very important. So at that time, we have no choice, just recruit the more physicians, more nurses to treat patients. So here, my experience, I recruit more physicians from the department anesthesiologists, because we have the similar background, we have a similar training. They can all they can manage the airway, they can put the line for the patients. So I'm happy about that. So actually this way works well for the organized new teams. And also safety, quite important, is top priority for the medical personnel. So here we should prepare enough the PPE, including the gloves, the gowns, the protective shoes, the respirator, the goggles, face shield, and all the kind of the PPEs. Also, we need to design the precautions for droplet, close contact, and airborne. In my department, I also set up the detailed protocols for how to wear the PPE and how to take off the PPE. Such is very, very important to avoid the infection from the virus. And also we regularly monitor the air, the virus level from the air, from all the environment, including the air, including the equipment, all the doors, all the telephones, to make sure all the environment safety for all ICU personnel. Why this is important? Because this transmission is quite easy, is quite frequently in the hospital. So here, I briefly talk about in the first months of the patients in my hospital, almost 40% of the patients related to the hospital infection, including the medical workers, including the hospital patients. So actually, more than 70% of the infected medical professionals from other departments, not from ICU, not from ER, because they don't know how to protect themselves. Also, another issue is because of the untypical symptom patients always occurred in the hospital. For example, the patients with diarrhea, but eventually they were diagnosed with the coronavirus. So this kind of patients easily to infect the medical workers in other departments. So this is very important to prevent, to avoid the hospital-related transmission. Also, we need to set up the triage policy. So during the early stage of the outbreak, you never imagine how the patients rush to the hospital. So here we set up the different levels, including the unknown fever clinics, ER, or determine which kind of patient should be to the hospital, which kind of patient should be to in the ICU, which kind of patients should discharge to home. So this is the policy for the triage. So next, I will briefly talk about the general feature of the COVID-19. So also from the patients in our hospital, almost the patients are middle-aged to old patients, and most of them complicated with the comorbidities. So actually, the COVID-19 infect relatively older people with comorbidities. So for the ICU patients, a little bit older and more comorbidities. And also regarding the symptoms and signs, actually the first most common symptoms is fever, and then fatigue, and then dry cough, and myalgia, and dyspnea. Also, about 10% of the patients presented with diarrhea and other abdominal symptoms, and eventually developed fever. So this kind of patients we were called atypical infection. So this patients is easily to infect the medical workers in other departments, so without any protection. So for the clinical process, actually the time from the first symptom to dyspnea, around 5 days. 7 days to hospital admission, and 8 days to ARDS. So about the lab test, so the most common problem is the lymphopenia. So for the patients in the ICU, the lymphocyte counts decreased more than that outside ICU patients. So the typical chest CT is the ground glass opacity. So actually, this is the very typical picture of the chest CT. Actually, for some patients, just the small parts of the ground glass opacity, but initially starting from the outer side of the lung. So for the diagnosis of the COVID-19, so actually we set up the criteria for the diagnosis. So including the epidemic history, and also the typical symptoms, including the febrile, fatigue, dyspnea, and also the lab test, the typical lab test opinion. Also, we need to exclude other flu tests. Also, the typical chest CT is the multiple patches. I just say the study from the outer parts, also from study from outer parts, from the lower parts of the lung. For the viral test, so unfortunately, the sensitivity is not so high, it's around 40%. Also, we perform the serum antibody test. So if the negative viral test, so we do the antibody test. So here we have confirmed the diagnosis, so including the positive viral test. We also have the clinical diagnosis. So only the symptoms, lab test, and typical chest CT, but without the positive viral test. So the most important here, I will focus on the management of for the critical ill patients. So actually, it's for the around less than 20% of the patients need to the ICU care. So here for the general features of these patients, actually the aptitude score, the SOVA score, not high, but you can see the P4 ratio quite low. It means all the patients have severe lung injury. So for the organ injury, so I just mentioned is most of the patients have the ARDS, and secondary to acute cardiac injury, including the arrhythmia and also shock. So because most of the patients with ARDS requiring the ventilation support, so here from our data is the only 10%, almost 50% of the patients requiring the intubation, the invasive mechanical ventilation. So this is for the data from the first month. Is only 36 patients in the ICU. So here we have other data. Is from February 7 to March 6. We have other 50 patients in the ICU, admitted in the ICU. So here you can see the output data is the P4 ratio quite low. It's only 115, and also you see the lung compliance is only 20. Also, they have high level of the IL-6 and low level of the lymphocyte. So for the mechanical ventilation, so here only 28% benefit from the non-invasive mechanical ventilation. However, almost 72% of the patients required invasive mechanical ventilation, and half of these patients with invasive mechanical ventilation switched to the ECMO. So this group of patients quite severe because they were transferred from other hospitals, from other ICUs. So it's very severe. And also you see the complications. Almost 94% of these patients developed the ARDS, and almost more than 60% of the patients have the heart problems, and 40% complicated with the shock, and 20% complicated with AKI. So here I will focus on the key points of the ventilation support. So here, if the patient came to the ICU, we will prolong the patient as early as possible. And for the lung protective approach, is top priority for the patients. So we will follow the lung protective approach in order to avoid the secondary lung injury induced by the mechanical ventilation. So we evaluate the model, the parameters set frequently, and switch and change the mode if the premier mode inappropriately. And also we titrate the PEEP and the tidal volume based on the transpulmonary pressure if possible, or the driving pressure. So keep the driving pressure less than 15. Keep the total pressure less than 28. And try to prevent acute pulmonary. And also be careful of the lung recruitment maneuver. So this is it's very difficult procedures, and try to set the highest people at 20. So otherwise, easily to induce the pneumothorax because the lung of this patient is severely damaged. Also, here I will briefly talk about when to switch from one model to another model. So initially, for the high flow, so actually high flow is not recommended in the room with only open window. So I highly recommend the high flow in the ICU with a negative pressure environment. But otherwise, it's not safe for the patients or for the medical personnel, because we monitored the air, the virus in the air with the different ICU, because I'm responsible for 2 ICUs. One ICU equipped with the negative pressure, the others only open window. So for the open window, so sometimes we found the positive virus near the ventilator if we use the high flow ventilation. So it's dangerous for the medical personnel. And also, of course, if the PEEP ratio around 200 to 300, we will first try high flow nasal cannula. We set up the flow rate at 40 to 50 L per minute. We try for 2 hours, and we evaluate the efficacy based on the pulse, the saturation, the respiratory rate, and also we calculated the LOX. LOX is equal to the rate minus the saturation divided by the FL2. So if after 2 hours the saturation above 93%, the rate less than 25, or the LOXY more than 3.8, and then continue HF the high flow. If the saturation less than 93%, the rate more than 30%, more than 30, and the LOXY less than 2.8, and we stop the high flow. So if stop the high flow and then go to the non-invasive ventilation. If the patient is still conscious, and we will give either the BiPAP or CPAP. So for the non-invasive ventilation, so initially the PEEP ratio is around 150 to 200. We will prefer using the non-invasive ventilation. But however, the BiPAP may raise the lung, so should be careful about that. So we usually set at the pressure like 12 or 8 or 5, and this is the parameter we set. Only we follow for 2 hours, So if the tidal volume is less than 9 ml per kilo, okay, continue. If the tidal volume more than 12, and we will intubate the patients, we think we consider this mode fail for the patients. And also, of course, for the mechanical ventilation, for the invasive mechanical ventilation, and if the PF ratio less than 150, we will prefer using invasive mechanical ventilation. So first, we need to test if the lung recruitment maneuver is okay or not. So I just said set the highest PIP around 20. So if not available, if the drive pressure more than 15, so then we will paralyze the patients and with the prone position. So also, we always follow the lung price. If the lung price going down, which indicate poor prognosis, and then probably we need to do another, we will go into another mode, such as the ECMO. So if the saturation, the PF ratio less than 150, the total pressure more than 35, they have the hypocapnia, and then we will go to the ECMO. So here, in my center, we so far we around about almost 17 ECMO already. So right now, almost almost 6 patients switched is win off from ECMO already. Others still on ECMO. So here is the flow chart for the ventilation for the COVID-19. So here it will be different from the patients with other ARDS. So be careful about the PIP. Be careful about the recruitment maneuver to avoid further lung injury. So last one, I will talk about the outcome of the patients with COVID-19. So actually from our database in the first month, the ICU mortality is around 18%. So this is in the first month. However, in the second month, from February to March 7, so we recruit other 50 patients. So I just mentioned this kind of patient is quite severe, and I think the predicted overall ICU mortality is around 25 to 30%. So here I also analyze the relationship between survivors and lung survivors. So here you will see the figure. The red line is the lung survivors. So the lung survivors is always with the high level of the white blood count, neutral counts, and the lower lymphocytes, and higher the dimer, higher urea level, and higher creatinine level. So, so this is about the patients in the ICU. We compare the survivors and the lung survivors. So here, including all the vital signs, including the heart rate, blood pressure, the PF ratio, the PEEP, the vessel pressure, and so on. So here, the yellow line is the lung survivors. So you can see the lung survivors always with the persistent hypercapnia and persistent lung injury and persistent fast heart rate, tachycardia, and also persistent high dose of the muscle relaxants, and persistent high dose of the vasopressors. So here we also compare the parameters in the ICU admission. So here we find the lung compromise. The lung compromise. The lung compromise is the predictor level for the ICU outcome. So if the lung compromise is too low, the patient will complicate it with the poor outcome. So conclusion. So the preparation of for the outbreak of the COVID-19 is quite important, as the medical resources always limited. So the transmission was frequently, and also with the hospital-related infection, and the atypical patients were probably the main source of the transmission. Critical ill patients to be older with comorbidities, specific symptoms, and other abnormalities. So titrating the models parameters of the ventilation supports with non-protective approach is quite important. The most common complications was ARDS, arrhythmia, and septic shock. So almost 70% of the patients need invasive ventilation. The lung compliance at the ICU admission and the persistently elevated hypocapnia predict poor outcome. Thank you for your attention. Thank you for your support.
Thank you, Dr. Peng. As we can see, those experiences are full of really technical know-hows. The different implication of those means life and death. The reason his ICU keep getting more patients is because they have achieved the lowest death rate at 20%, and before more critical ill patients were transformed there. And as we are preparing, those experiences would really mean a great deal to the people who will face it. It's worth noting that all three doctors are still working on the front line, and they took their valuable time from their rest to be with us. It's now about 11, 12 o'clock over there in China, and they'll be seeing patients the whole day already. And all three have took care and time to really put the presentation in English to make it easy for our audience. So on behalf of everybody, we still have several hundred doctors online. I want to express our deep, heartfelt thanks to all of you, and particularly for what you have contributed to the collective knowledge about this virus and to what you have done to protect the people over there. We hope all the experiences you shared here would help us as we're embracing a battle to protect our people here. And as we can see that in this virus, we have now found a real worthy adversary. It is at least 10 times more lethal than flu, and it is more clever in the sense it is both fatal as well as infectious. And at the same time, it attacks both the lung, such as SARS, but also it severely damaged our immune system, the same way that HIV does. This could really be with us for a while. We have received numerous questions that cover from general topics as well as a specific technical in nature. What we will do is to really organize all of the questions and send it to the three doctors. And we will have our team to have separate interviews with all three doctors, record their answers and disseminate it both in video recording, audio recording, as well as text to all of the people who wish to receive them. And please do write to us at himalaya@hemcap.com. If we have learned anything from Chinese experiences, it seems to me has boiled down to three broad categories. Number one, aggressive testing, aggressive tracking, to track down every single one get infected using either technology or strong administrative measure, so that we have a real sense of who they are, where they're located, and therefore to prepare where the inevitable outbreak is going to be. Number two, to differentiate a treatment of people who are in danger of being infected, who are infected, who have mild syndrome, and who have severe or critical symptoms. To have a differentiated treatment of all of them, from quarantine, home, to shelter, using gymnasium, sports stadiums, hotels, etc., to a hospital bed and critical care. Number three, to have a robust reserve for the critical care hospital bed. That in early days of Wuhan, that is ill prepared, which resulted in a large number of deaths, which now we see a repeat in Italy. Pretty soon, that China has mobilized resources from all over the China to really send to Wuhan. Altogether, 42,000 doctors and nurses from all over China were sent to Wuhan to fortress the defense. And Dr. Cao is a fine example of all those people who have been stationed there since 2 months ago. And so to really achieve where they are is not easy. It may not be repeated in other countries, depends on the social structures of different culture and different society. But I think the experiences that China has been through is extremely valuable to all of us here. Unfortunately, due to all sorts of different reasons, ideological and sexual, that those 2 months of experiences, valuable experiences, are largely lost in America and in the West broadly. Unfortunately, virus does not understand the differences, does not understand the term trade wars. It doesn't recognize borders. It really goes wherever they want to survive. And so we're all in it together. And so we will continue as long as people find it valuable to share those experiences and learnings out of this enormous fight that China has put together, and all those tremendous work done, represented by those three great hero doctors in my own mind and in the mind of a lot of people. And so we will continue to do that. Now it's about an hour and a half now, so we're coming to the end. A lot of people might have other plans, but I assure you that I will put everything in video, audio, text format, and disseminate to all of you if you wish to receive them. And we will follow up with all the answers and record all the answers for the questions that have been posed to us from the three doctors with their permission. And again, distribute it back. And here I want to recognize lots of the volunteers that have really made this available. From the very beginning of the Wuhan outbreak, we have organized a volunteer group, 2020 Helping Wuhan. And about a week ago, we have formed another volunteer group called 2020 Helping Seattle, broadly United States. And many people have played a critical roles in there. I won't recognize one by one, except that together now we have resources that covers many different fields. to make sure at the beginning to disseminate those vital learnings and experiences into the United States as fast as possible. I will come and invite everyone who want to join the effort to come together. Together, let's really do the best we can to protect our community, our family, our cities, our state, and our country. For that, I want to thank everyone again for participating, for what you have done, for what you have contributed. And I thank everybody. We have several hundred people from all over the country, from all the important institutions, medical hospitals, medical schools, that together we truly represent the best of hope for our country. And we would love to help and work together in the days and the weeks to come. So thank you, and we'll resume soon. Bye-bye.